Hi, this is your discussion about Parkinson's disease. So Parkinson's disease, class, take note that your Parkinson's disease is a central nervous system problem, and this is related to the decrease of your dopamine. Okay, so it's a debilitating disorder affecting motor ability. So you highlight motor ability because there are no sensory problems related here. Oftentimes, the manifestations of your patient is related to motors. So you have the four cardinal symptoms summarized by the acronym TRAP. So you have tremor, rigidity, akinesia or bradykinesia, and then you have your postural instability and postural changes. So notice that we would have the acronym BRAT and then we also have the acronym TRAP. So regardless, the definition of which or the meaning of each of these components are the same. Now, look at that there are two types of Parkinson's disease. So you have your primary Parkinson's and then you also have your secondary Parkinson's. The most common disorder that our patients will be encountering is primary Parkinson's, meaning there is no other causes on the decrease of the dopamine other than a problem within the brain functioning of your patient. Okay, so which is the production of your dopamine in the substantia nigra. On the other hand, when I say secondary Parkinson's, recall your medications in psychiatry or in your psychiatric nursing. Okay, recall your antipsychotics. That's a typical example of your secondary Parkinson's as an extrapyramidal symptom. Okay, so in your secondary Parkinson's, okay, for example, the use of your typical antipsychotics would decrease the levels of your dopamine 2, which would lead to your extrapyramidal symptom, and one of that is your pseudo-Parkinsonism or your secondary Parkinson's. Management for both seems to be the same. Then you have the etiology. So it says it is attributed to genetics. However, only 15% of those who have Parkinson's disease have a family history of it. So for the rest, the cause of Parkinson's disease is usually unknown. Then it could also be caused by atherosclerosis and then excessive accumulation of oxygen-free radicals. So when I say class-free radicals, these are unbound elements which are circulating in the system. Then you have viral infections, okay, also your brain trauma, and then the chronic use of antipsychotic medications. You also have your environmental factors and then advancing age and then the decrease of your estrogen level, especially if your patient is going towards menopause. So plus for the environmental, that would include the exposure to pesticides, herbicides, industrial chemicals, and metals, and then drinking well water. Okay, especially unexamined well water which would have a lot of chemicals. Okay, on the other hand, for the estrogen levels, it would theory has it, okay, or studies has it that estrogen would trigger the release of dopamine. Hence, a decrease in the level of estrogen also results to the decrease in the levels of your dopamine. Now, for the pathophysiology. So we are looking into the atrophy of the neurons of the substantia nigra. For that reason, it is more common in old age because if you can notice, okay, or if you can recall, atrophy of the brain tissue is very common among old age. Now, atrophy of the neurons of the substantia nigra would result to the decrease of dopamine release. And then this would disrupt the normal balance between your dopamine and acetylcholine. So for that reason, there will be impairment of extrapyramidal tracts controlling body movement. And then you will have the manifestation of your trap. Okay, so class, this is a part which shows your substantia nigra. Okay, and this is the diminished substantia nigra as seen in your Parkinson's disease. So for you to have a picture of where your substantia nigra is, you can see it on the left side of your screen. So this is where your substantia nigra is located. Okay, so this is a cross section of your brain at about the level of your eye. So substantia nigra is located there. Okay, so as you can notice in Parkinson's disease, the substantia nigra is diminished. Now, the first sign that we have mentioned is tremor. So class, the tremor tends to be slow, unilateral, and then it's a resting tremor, meaning it occurs if your patient is at rest. It disappears with purposeful movement and during sleep. Meaning if your patient plans to do a movement, kaya purposeful movement, the tendency of the tremor is to decrease. And then when your patient is sleeping, the tremor also tends to be absent. Then, evident when the extremities are motionless or at rest, once again. And then, class, your patient would have pill rolling motion. Okay, it's as if they're rolling a pill, class, on their fingers. Then you have rigidity. So class, your rigidity, that would refer to its caused, by the limb to move in jerky movements. So it is also sometimes referred to as your lead pipe rigidity or your cogwheel rigidity. So your patient is also manifesting with mask-like facial expression. So class, it's like your patient is wearing a mask. Okay, they are not showing any emotions on their face. And then early class, there is a presence of shoulder pain. And then you also have micrographia. Okay, micrographia as in your patient would write in small. Okay, the tendency is that they would be writing small letters because class their hand will not be able to move at big movements to write the big letters. Then you'll have your dysphonia. Okay, when I say dysphonia, that will be difficulty on phonation. The tendency of this patient is to have abnormal voice or hoarseness of voice. Just to closely monitor your patient, you need to watch out because there is involvement already of your voice box. Now, you also have your bradykinesia. So, brady is slowing, kinesia is movement. So, it's overall slowing of active movement. It's one of the most common features. And in fact, if your patient will be frozen in their place, okay, it is what we refer to as your akinesia. So class, in akinesia, there is absence of movement. Absence, akinesia. Then you have your postural instability. So the tendency of your patient is to have loss of postural reflexes. And then when the patient stands with head bent forward and walks with a propulsive gait or shuffling gait. Class, the purpose of your patient for doing this, that their head is bent forward and then walking with a propulsive gait, is for them to maintain balance because they are having tremors. That's why they're having the postural instability also. Okay, so they are leaning their head forward in such a way that they will decrease the risk of falling. You also have the autonomic symptoms such as your diaphoresis. Okay, you also have paroxysmal flashing. Your patient may have orthostatic hypotension, gastric and urinary retention, okay, constipation, sexual dysfunction, and even your blepharospasm. So when I say blepharospasm, class, it is involuntary blinking or twitching. Then psychiatric changes. You need to watch out for this. Depression, anxiety, dementia, delirium, auditory hallucinations, and visual hallucinations. The presence of psychiatric changes, especially that of dementia, delirium, auditory hallucinations, and visual hallucinations may be minimal class. However, you still need to monitor because this may be life-threatening on the part of your patient. Then you have your mental changes. Okay, mental changes or intellect class is not usually affected, okay, when you're talking about Parkinson's disease. So you have your possible cognitive deficits, perceptual deficits, memory deficits, and then intellect. So class, again, for the intellect, it is not usually affected. Okay, so a patient class with Parkinson's disease may be able to function as a full-time professional. However, class, they would just have difficulty in carrying out their writing task because, of course, of their tremors. Then you have personality changes. They have a tendency to be emotionally labile. Okay, they have rapid mood swing and they get easily upset. So, class, this is usually attributed to the irritability brought about by the disappointment of their inability to carry out a certain task. So let's go to the laboratory test. So class 1 example is your CBC. So your CBC is intended to monitor for hemoglobin and hematocrit levels. These patients would usually have decreased hemoglobin and hematocrit. Now, chemistry profile, there is decrease of protein and albumin levels among your patients with Parkinson's. And then drug screening. Your drug screening class is done to determine medications that can cause your secondary Parkinsonism. And then EEG. In EEG, what can be seen, class, is that there is slowing of the pattern and disorganization in your EEG. Okay, that's why your patients, class, with Parkinson's disease also have or tend to have slowing of processes. Then, you have your upper GI series with small bowel fallow. Class, for your upper GI series with small bowel fallow, okay, you would usually find out delayed emptying, distension, and possibly megacolon with severe constipation. And that is brought about by the decreased innervation. Okay, again, that is brought about by the decreased innervation of your parasympathetic nervous system. Okay, so again, class, there is delayed emptying, distension, and possibly megacolon with severe constipation. Now, in your video fluoroscopy, okay, of the client while swallowing barium, you would notice that there is slowed response from the cricopharyngeal muscles. Okay, so especially that when you are swallowing. Now, Class, when you have the cricopharyngeal muscles, they are located here. No? So this is the lateral section of your throat, okay, found in your neck. So class, your cricopharyngeal muscle is located here. Class, your cricopharyngeal muscle would act as your functional upper esophageal sphincter. Okay? So class, meaning by the time that your patient will be swallowing, your cricopharyngeal muscles should be relaxed. And then by the time that food is already down, your upper esophageal sphincter should be closing. Okay, so in your patient with Parkinson's disease, due again to the decreased response or decreased innervation of the nerves, the tendency is that class your UES or your upper esophageal sphincter, particularly class your cricopharyngeus muscle, okay, will not be responding properly. And then class, you have your PET scan and your SPECT class. Of course, this is used to detect metabolic activities inside your brain. So there will be slowing of activities inside your brain because of Parkinson's disease. Now, what are the medications that we use for this patient? So you need to remember that each of the classes of these medications would have different purpose. Your levodopa is one of the mainstay treatment in your Parkinson's disease. Okay, it is said to be the most effective agent. So class, your levodopa is considered to be dopaminergic or dopamine agonist. In other words, class, your levodopa triggers for the production of dopamine, and then other than that, your levodopa could be converted to the dopamine that can be used by the body. Okay, so it is converted to dopamine in the basal ganglia, producing relief of symptoms. So take note that the target site for the conversion of your levodopa is at the basal ganglia. Now, recall that you will have also your carbidopa. So class, your carbidopa is oftentimes given with your levodopa. Levodopa, I mean. So class, your levodopa rapidly metabolizes in the bloodstream. Supposedly, our goal is for levodopa to be processed inside the brainstem. Okay, or inside, I mean class, your substantia nigra, okay, in your basal ganglia, where dopamine should be present. Okay, now, the problem with your levodopa is that by the time it is in the bloodstream, okay, and by the time it will undergo the hepatic first pass, the amount of drug is significantly reduced. Okay, significantly reduced to the level that could not be useful already on the part of your brain, okay, or your basal ganglia. So, for that purpose, class, your carbidopa is combined with your levodopa. The purpose of your carbidopa is to avoid the metabolism of the levodopa before it would reach the brainstem. Okay, so that's why the common combination is your carbidopa, levodopa. Plus, the prolonged use of your dopaminergic agonist would lead to the following signs: no? Confusion, hallucinations, depression. Your patient may also have sleep alterations, and then dyskinesia. Okay, dyskinesia class usually occurs if the patient have been using the medication for 5 to 10 years. And then class, there will be an on and off phenomenon. You try to find out what is on and off phenomenon in dopaminergic agonist use. And then class, you will have your neuroleptic malignant syndrome. Okay, so review your lessons in psychiatry. When I talk about neuroleptic malignant syndrome, this usually refers to an idiosyncratic, meaning treatment-related reaction. Okay, usually using your antipsychotic drugs. Okay, so of course, class, we're dealing here with Parkinson's. Okay, we are using antipsychotic drugs. Okay, and then it is characterized by fever. Your patient may have altered mental status, and then muscle rigidity, and then also autonomic dysfunction. So your neuroleptic malignant syndrome is managed symptomatically. However, if not managed, this may be life-threatening on the part of your patient. Then you have your MAO inhibitors. So class, your MAO inhibitors, okay, your monoamine oxidase inhibitors. So class, you have your siligilin. Okay, that's one example. So class, your siligilin would inhibit the dopamine breakdown. Remember, the function of your MAO, your monoamine oxidase class, would break down. Okay, it would break down your neurotransmitters such as your dopamine. So it breaks down your norepinephrine, even your epinephrine, and even your serotonin. That's the function of your MAO. Now, your MAO inhibitors would inhibit this oxidation. Your MAO inhibitors would inhibit this breakdown. Hence, the goal of your MAO is to increase the levels of your dopamine. However, class, if your siligilin will be combined with levodopa, you are increasing the risk for adverse reactions towards dopamine. Okay? And your patient may have the following signs and symptoms: orthostatic hypotension. Okay, changes in movement would lead to hallucination and even confusion. Okay, so you are aggravating the adverse reactions class of your medications. So be careful when you are combining these two medications. Now, your health teaching for a patient who is taking MAWIs. Okay, your patient who are taking MAWIs should avoid food and beverages containing tyramine. Okay, so class, avoid tyramine containing food products. That would include your aged cheese, that would include your wine. Okay, it would include products which are being fermented. Okay, products that undergo fermentation. So, class, tyramine products should be avoided. Why? Remember, your tyramine is also a precursor in the production of your neurotransmitters, particularly class your norepinephrine and your epinephrine. So, if you would combine class tyramine, if I would combine tyramine plus MAWI, okay, you are increasing the levels of your norepinephrine and epinephrine to very high levels. And that would lead class to what we refer to as your hypertensive crisis. Okay? And we don't want that to happen to our patient. And you remind the client to continue with this restriction, okay, 14 days after the discontinuation of the drug. Okay, 14 days after the discontinuation of the drug. Okay, why class? Your MAWIS would stay in the bloodstream even up to 14 days after you have discontinued the medication. So this discontinuation of your medication class, because of the prolonged half-life of your MAWI, okay, you need to practice still the precautions. Okay? Now, there are also class antipsychotic medications that would interact with your MAWI. So the same procedure, okay, the reaction or your MAWIs or your new antipsychotic drugs should not be started unless MAWI has lapsed for 14 days. Another set of medication that we can use for this patient is your dopamine agonist. Class, your dopamine agonist would act by directly activating the dopamine receptors in the brain. Examples of which are your pergolide and then your bromocriptine. So bromocriptine is more commonly used, especially your parlodel. So it increases the therapeutic effects of your levodopa and could reduce the fluctuations in motor symptoms. Oftentimes, class, this is also used to delay the treatment with the use of levodopa. So we usually start first with dopamine agonists such as your bromocriptine before we start your patient on levodopa. Meaning, class, if your bromocriptine or pergolide would be working on your patient, okay, we will not be using levodopa yet. Okay, because levodopa would have more side effects compared to your bromocriptine and pergolide. Now, anticholinergic therapy. So class, your anticholinergic therapy is intended to counteract the action of your neurotransmitter acetylcholine. Because remember, there is an imbalance between your acetylcholine and then your dopamine led, which is caused, by the decrease in the production of your dopamine. So to address this imbalance, what we are using is that benztropine mesylate. So class, your benztropine mesylate is intended to control your tremors and rigidity. And this is done by counteracting the action of your neurotransmitter acetylcholine. Then you also have your antivirals. Okay, particularly we are using your amantadine. So class, your amantadine hydrochloride or your Simetril would reduce the rigidity, the tremors, the bradykinesia, and postural changes experienced by your patient. Then, we have the following surgeries. So, class, the surgeries are referred to as stereotactic procedures. So, when I say class stereotactic procedure, so you have your palidotomy and then you have your thalamotomy. Okay, so class, notice here on the illustration, where is your thalamus and then where is your pallidus. Okay, that's why it's referred to as palidotomy and thalamotomy. So class, in this procedure, a tiny electrical probe would be placed class on the pallidus, okay, which is part of the basal nuclei of the brain, and then it would be heated at around 80 degrees Celsius, no, for about 45 to 60 seconds. The purpose of which is to destroy a small area of the brain. So class, this is ablative, meaning class, it would destroy part of your brain, and the purpose of that is to interrupt the pathway that would alleviate the tremor or rigidity. So class, when I say pathway, no, that will be the pathway wherein your neurons or impulses, that would trigger your tremors is passing through. So to prevent these tremors, class, what is being done in palidotomy and thalamotomy is to destroy this pathway. So another surgery is your deep brain stimulation. In your deep brain stimulation class, a surgical implantation of an electrode into the brain is done that would increase the release of your dopamine. For the rehabilitation, your patient would need to undergo physical therapy, occupational therapy, and even speech therapy. So class, for the physical therapy, it is intended to improve coordination, balance, gait transfer, and to prevent contractures. Remember, your patient is having tremors and your patient is also having postural instability. In occupational therapy class, we are trying to assist the client to adapt to the changing abilities pertinent to work, self-care, and recreational activities. And then your speech therapy is not only intended for the purpose of speech, but also for the chewing and swallowing. Okay, so your patient need to be trained as to how to hold their spoon, their fork, and then how to use their cups in such a way class that they would not fall when their hands are shaking. Okay, they are usually advised class to take their medication before meals in such a way that by the time that they have their meals, the medication is in full efficacy. So the following nursing diagnoses are evident for this patient. So you may have impaired physical mobility, you may have impaired verbal communication, imbalanced nutrition less than body requirements, plus they're having tremors while they are eating, so their tendency is to stop eating, self-care deficit, and then ineffective individual coping. Now, for the impaired physical mobility that's related to tremors, gait pattern disturbances, and alterations in body positioning. So your patient would need to perform range of motion exercises twice a day. A consultation with a physical therapist is recommended, and then they need to ambulate at least 4 times a day. You need to educate them on the use of assistive devices such as your canes, your splints, and even your braces. Okay, that would help them in ambulation. Then, class impaired verbal communication. So you would need to remind the client to speak more loudly if possible, and then develop other methods of communication. Okay? Then you have your imbalanced nutrition less than body requirements. Usually, class, we would recommend thick food products for this patient, okay, for proper consistency, okay, as determined by the client's swallowing function. So the thicker food product class is recommended for your patient to prevent aspiration. They're weighed weekly class so that they will be aware if there is a decrease in their weight. Okay, and then we teach eating methods to decrease their tremors. Now, try to search if what are the possible eating methods that would decrease their tremor. Okay, so these are among the concerns in your Parkinson's patient. So class, there are several Parkinson's patients who would be working now full time. So this does not disable them to work, but however, class, you need to have the medications so that their signs and symptoms are properly controlled. Okay? Our next topic is supposedly focused on spinal cord injury, but prior to that, I would like to discuss your amyotrophic lateral sclerosis, which is also a neurologic problem. So after your amyotrophic lateral sclerosis, we will proceed to your neurologic problem on spinal cord injury. Okay. Thank you very much for your attention.